today's lecture will be very general, okay, very general that I'm going to talk, very general. Because when we say each of those things, like a pulmonary function test is a lecture on its own. You know, the peak expiratory flow rate is a lecture of its own. So let's take this patient that comes in from outside, okay, and has come into you with a respiratory failure, and you have a history saying that this patient has been on bronchodilators. This is the kind of history that you will probably get in the ICU. You will not get a patient that comes de novo as asthma or de novo as COPD or the first time you're diagnosing. That is very less likely. It is not possible. You will probably get a patient who has been in respiratory failure for a while and then come with an acute exacerbation. That's how it's going to be. Okay, so if this patient comes into you, say he's a 50-year-old gentleman who's been on bronchodilators, and yesterday he started feeling more breathless, and he came to the casualty and they found out that he's breathing at a rate of more than 25 per minute. So here we have a patient who's coming with respiratory distress. Any respiratory rate more than 25 means it is distress, isn't it? Isn't it? It's 25. So now this patient deserves an ICU. It's but obvious this patient deserves an ICU, right? So now this patient is coming to the ICU. How will you manage this patient? Somewhere this patient is coming to you. So what are your things that you're going to look at here? So let's take it one by one. Okay, you are going to definitely have a patient whose pulse rate is going to be fast. Unless the patient is a beta blockers, and the chances of him being a beta blocker is almost not possible. Nobody would be starting on beta blockers, at least in the general physician arena. He might be on everyone, but most often than not, we at a pulse rate that is fast. So what are the investigations you would like to do here? To begin with, we are not going to the management first. We'll go to what are your first concerns on this patient, and what are you going to how are you going to manage it? What's your first concern that this patient comes to you?
Maintaining the oxygen and airways.
So your first thing is to maintain the airways. You're absolutely right. The first thing would be to actually maintain the airways. Okay, if you maintain the airways, then you can actually proceed in what's going to happen ahead. Okay, unless you maintain the airway, everything is going to just go down. Everything is just going to go down. So let's maintain the airway here. So which of these patients would so maintenance of airway, we go to that management part, we go to the management part. So which are the conditions that you will feel that this patient is not maintaining the airway? Yeah, so Alia says something called CO2 retention. What is she saying? That this patient can be extremely somnolent. Okay, if the patient was extremely somnolent, there is a possibility that this patient might lose the airway. Okay, he is extremely somnolent. But putting a tube through in these patients can be alarmingly dangerous. You will not get this patient somnolent. That means this patient has gone to another hospital, become somnolent, then complete. It won't be like that. Okay, so like that. You go to another hospital, become extremely somnolent, not managed, then come to you, will be very somnolent. So chances of you having a patient coming with somnolence is very less likely. Okay, so why do you think these first so if you come to somnolence, why do these patients get somnolent for that matter? Why do they get drowsy? CO2 narcosis that you talked about. Why do you think that happens? Why do you think that happens? Any idea?
The problem is in expiration, that the patient is not able to expire the carbon dioxide.
So there are two things to it. The patient was not expiring properly, was getting tired. So the first thing that comes to you is diaphragmatic fatigue.
Fatigue.
Okay, it is the diaphragm that is responsible for 80% of your expiration, isn't it? So if your diaphragm is getting fatigued out, these patients will not expire. Right? Since the exhalation is not okay, these patients will actually get more and more tired and then get somnolent. So the implications of that are multiple. What is the implication? The implication is that now if you want to treat this patient, what will you require? You will require this patient to be either BiPAP or intubated. So the answer to this is how quickly you will reverse that diaphragmatic fatigue. So that will determine your time, how long you want to put the patient on the ventilator or on BiPAP. Understanding? Clear? So if the patient is getting diaphragmatic fatigue, unless the diaphragmatic fatigue goes out, this patient will still become somnolent if you try to remove the ventilator. For example, what you will see, you will have a patient who is somnolent. Okay, he's absolutely in CO2 narcosis, you find the PCO to be 120. Okay, now you have intubated this patient. You've intubated this patient, immediately the patient wakes up. That's what normally occurs. The patient immediately wakes up. The patient wakes up, patient becomes conscious, patient says remove the tube out. This is what occurs in these patients because blood pressure is normal, pulse is normal, oxygenation is well maintained. You just remove his carbon dioxide and he becomes normal, isn't it? This is what normally happens. Now, what can be the most fatal mistake at this time? The most fatal mistake at this time would be to contest him for a weaning trial and extubate him. That would be the most dangerous and fatal mistake that you can come to. Why? Why is that so? Because the reason that he has become somnolent is the fact that his diaphragm is fatigued out. We haven't done any kind of thing to the diaphragm to get its fatigue out. So the moment all that we've done is put in a ventilator, carbon dioxide has come out and the patient has become awake. But the diaphragm has remained the same, fatigued. So you try to get the ventilator out, these patients will not do it. You try to do a weaning trial, they will fail weaning trials. And then you will say, sure, we'll just give a trial. That is not the way you're supposed to do. Okay? Practically what you have to do, give rest. So the average amount of time that this patient would take to get rest from diaphragmatic fatigue will be somewhere between 24 to 48 hours. So once you intubate this patient, which should be the last thing you're going to do, okay, you should probably not try to remove the ventilator for 24 to 48 hours. This is very important because you will find the patient to be very stable. You will find the patient to be awake. You will find the patient to be very conscious. You will get tricked to understand maybe I should take a call and take him off the ventilator. But that should never be done. So 24 to 48 hours is the time that you must take for the diaphragmatic fatigue to come down. Okay, that holds good even for a BiPAP. So say you have a patient who comes in with BiPAP, with the situation that you don't need the airway to be saved. He is having CO2 narcosis, say 70, 65, 70, something like that, which is dropping the pH. Okay, so you decided to give BiPAP. Now the reason to give BiPAP is multi-pronged. You want the diaphragm to get rested and you want to actually ensure that the patient is ventilated well. That is the reason you are giving BiPAP, isn't it? Now you give NIV, these patients start looking better. And then you say, chalo usko nikalo, usko, let him be eating his food properly, let him, no, again that is wrong. The answer is let the BiPAP remain for say 2 days. BiPAP is not as good as ventilator for the rest pattern. But if you give BiPAP, let it be there for 1 or 2 days completely. And then after 2 days, you probably give nocturnal BiPAPs or intermittent BiPAPs. Don't try to get off the BiPAP urgently. Again. So understand, so the first reason that we talked about was CO2 narcosis, which occurs because of diaphragmatic fatigue. Clear on this? So this is how you tackle diaphragmatic fatigue in patients of acute exacerbation COPD or asthma for that matter. Both of them will respond the same way. Clear? Now the other reason that some of these patients would get CO2 accumulation is because of the fact that if you give a large amount of oxygen. Now this is very doubtful why this occurs. Because why do you think that occurs? What is the reason you think this might occur? It should reduce. No, they don't reduce. So the entire thinking is that the respiratory drive will come down because the patient is used to a certain level of hypoxia. They are to a certain level of hypoxia. Of course, that has been disproven and that has been a matter of debate whether that really occurs in the first place. But what can occur in this case is there's something called as the Haldane effect. Now, what is the Haldane effect? The Haldane effect is that deoxygenated blood holds on to carbon dioxide and transports it better. Deoxygenated blood holds on to carbon dioxide, okay, and transports it better. Right? You give oxygen, the proportion of deoxygenated blood comes down, and since the movement of carbon dioxide actually reduces. Are you understanding? So this is one. Now, so they tested this whether this really occurs. Okay, this really occurs. So they did a few experiments and they actually they actually gave patient oxygen to figure out what is happening. They found out that carbon dioxide was going up by 23 millimeters of mercury when they gave 10 minutes of 100% oxygen. When they gave 10 minutes of oxygen, the PCO2 went up by 23 millimeters of mercury, but only 5 millimeters of mercury actually came from Haldane effect. So the Haldane effect is just a small element of the entire story. The bigger element of the story is physiology. Now, what is physiology? In this physiology, what you're going to look at, you have emphysematous lungs. You have lungs that are emphysematous. Right? What is happening in emphysema? The alveolus is getting spoiled. That means the surface area that is required gas transfer is actually reduced. Okay, so emphysematous lung is destroyed lungs after all. Not this. Okay, in COPD they are destroyed lungs. They are not passing oxygen or carbon dioxide. So what happens as a result of this? The surface area of the entire lung, of the gas surface area will actually come down. Clear? And when the gas surface area comes down, the nature has its mechanism of vasoconstricting the entire other side. Okay, the pulmonary circulation gets vasoconstricted. This is also called as hypoxic pulmonary vasoconstriction. This is occurring in these cases. This is preserving your VQ. It is not allowing, it is preserving the way the blood is, the blood is actually getting oxygenated. How? Because if it is going through an area that is not getting oxygenated, it is reducing that amount. It is reducing the amount of blood that goes through an area that is not oxygenated. You understand? Imagine that you had this much of pulmonary circulation and you had this big alveoli which is now contracted. That means this much amount of deoxygenated blood is actually mixing with the circulation. Now you are actually vasoconstricted. When you vasoconstricted, the amount of deoxygenated blood that is actually mixing with the circulation now will reduce. This is hypoxic pulmonary vasoconstriction, which occurs as a defense mechanism for most of our patients. Okay. Now what happens if you give oxygen? Suddenly there is a huge intake of oxygen that has come inside. What happens to hypoxic pulmonary vasoconstriction? Suddenly dilates. And it dilates not in that area, it dilates everywhere. Since it dilates everywhere, even those areas where there was hypoxic pulmonary vasoconstriction, it will get released. And that will cause this patient to get a large amount of CO2. You got the point? Which will then cause CO2 narcosis. Clear on that? So there are 2-3 reasons. Apart from that, there are a few more reasons that happens. But these are the two main things you must understand about oxygen. So this does not mean that you don't give oxygen. You still give oxygen because the death occurs because of hypoxia at times. So what is the limit at which you probably want to give oxygen? Somewhere between 85 to 88. In those very difficult patients, somewhere between 85 to 88 is what you probably want to give. Clear on this? Clear? So I don't want to give that oxygen. That is the idea. Clear on this? Alright. So now, so Zaman, you have this patient with you again. So you said the first thing that she was worried was the fact that you will have CO2 narcosis and the patient might lose the air. What is the other thing that you're worried about? How do you judge the severity of this case that comes to you? When will you say that this patient is very severe, not severe, it's okay, mild, and people will want? You'll have to make that distinction, right? How severe is this patient? So it's important that you remember that there are a few indices that we use in COPD. Okay, one of the indices that we have is something called Board Severity Index, BODE, Severity Index. Okay, now this Board Severity Index actually depends on the forced expiratory volume that is there. It depends on the MMRC scale for dyspnea. What is the MMRC scale for dyspnea? This is something that you should be mentioning in almost all of your patients that come in with respiratory failure. What is MMRC? So MMRC means I don't have any dyspnea at all. Then I'm completely fine. That is MMRC grade 1. I will say MMRC grade 5 means I can't even finish a sentence. Okay, anything between that is 2, 3, 4, 5. That means if a person can walk on a level ground for more than 15 minutes and then get tired, okay, then it's MMRC grade 2. Okay, if he walks slightly uphill and gets breathless or can't walk for more than 15 minutes, that's MMRC grade 3. Okay, if the patient gets walked with minimal activities, MMRC grade 4. And when the patient is listening at rest, it becomes MMRC grade 5. Are you understanding? So this MMRC grade is a part of the board index. Board index has got 4 things. It's got MMRC, it's got FEV1, and I think 2 more things it has got. I don't know exactly, some board index. Board severity index. You should know the name. It's got a scale of 1 to 10, where 10 is very bad and 1 is okay. Clear? BODE index. Clear on this? Acute exacerbations in the last 1 year also comes into that. I think acute exacerbation in the last 1 year comes into that. Post expiratory volume comes into that. And MMRC again, body mass index less than 21, more than 21. That is what comes into this. 40%, so this is what it is. Clear? So the board index is a part or parcel of understanding the severity of the illness. Now, obviously this is a clinical call, so we'll obviously look at the clinics of this patient, we'll look at what it is happening over here. So if this patient has got a very fast heart rate, he is diaphoretic, this is the event that is going to about to die. Remember when the patient is about to sweat, it's intense release of epinephrine. If the patient is sweating, it is an intense release of epinephrine. Okay, so that is generally a harbinger of that this patient is probably going to just collapse and die. So if this patient is markedly diaphoretic, okay, markedly tachypneic, this goes in favor that this patient will probably just go down. Remember this, an acute exacerbation of COPD will always have a combination of three things you have to rule out. One is acute exacerbation with pneumonia. Okay, acute exacerbation of COPD with pneumonia is one factor why they get exacerbated. Okay, the other factor is acute exacerbation with pulmonary embolism. There is a second factor that comes into the story. Right? And the third is acute exacerbation goes overdose on a large amount of sleeping pills. That's part 3. Okay, that's how you would present. You would have this presentation. Okay. Now acute exacerbation pneumonia. What does this mean? It is a clear-cut given. If there is no sputum, if there is no fever, if there is no patch, this is less likely that it is acute exacerbation from pneumonia. Are you understanding? More often than not, every patient who comes into the ICU, 99% of them will require antibiotics. They will require antibiotics. They are not in the ward. The distinction whether to give antibiotic or don't give antibiotic is actually in the ward, where you are dealing with just an acute exacerbation versus acute exacerbation with pneumonia. All those patients who come into the ICU, by definition, will require an antibiotic. Okay, and whenever you give antibiotics in COPD, it makes a lot of sense to give combinations of macrolide along with the third generation cephalosporin. The third cephalosporin and macrolide is what you probably want to do. So now we don't have to think if this patient has come with AECOPD, acute exacerbation of COPD or acute exacerbation of asthma, he is sick enough to come into the ICU. This patient requires antibiotics, and it has to be a combination of a third generation cephalosporin along with the macrolide, conventional. Okay, when you say macrolide is azithromycin. Okay, azithromycin, clarithromycin, all these things are the macrolides that we're talking about. Okay, and the third generation cephalosporin, we say it is monocyl, ceftriaxone, something like ceftriaxone. Clear on this? Acute exacerbation of COPD with pneumonia. Of course, now the question comes: is this really pneumonia? Is it not? That is the reason that I'm going to look at what is the color of the sputum, whether there is a patch in the lung. Okay, and the third thing you may want to do is a procalcitonin. You may want to do it. It's not essential. Okay, why? Because say if the procalcitonin is very normal, it is low, it is highly unlikely that this is a bacterial infection. Because if it's a pneumonia, you will probably see some procalcitonin going on. You will probably see procalcitonin. Don't think that procalcitonin is to diagnose a pneumonia. It is not to diagnose a pneumonia. It is not to diagnose anything here. We are just getting an idea that if the procalcitonin is high, then there is a possibility that this acute exacerbation of COPD may be because of pneumonia. Because there is a big doubt here. Even acute exacerbation of COPD, it's a big doubt whether there is pneumonia or not. The sine qua non would be the presence of a patch on X-ray and the presence of an ultrasound finding that shows consolidative shadows. Okay, a sputum more often than not will always have multiple organisms. More often than not, COPD sputum will have multiple organisms because they are going to be on bronchodilators, which include steroids. They are going to be on bronchodilators. Their airways are usually populated by multiple different organisms. So the sputum really will not make a big difference in these patients, in acute exacerbations. That's why this is a certain class of patients, say you intubate, that you probably want a directed bronchoscopy. You want a directed bronchoscopy of that patient. There's a pneumonia, directed bronchoscopy. So the antibiotics becomes even difficult here. You must understand this. 80% of the times, these COPD patients will have a combination of streptococcus, if it is infective, or Moraxella catarrhalis, like bugs, Mycoplasma, Moraxella. These would be the ones that will come 80% of the cases along with streptococcus. Getting a Klebsiella, getting a Pseudomonas is not, this is not hospital acquired. Patient is coming from outside. Patient is getting community acquired bugs. So when you see community acquired bugs, say Streptococcus, Moraxella, Mycoplasma. These are the things we are looking at. We're not going to look at Klebsiella. So just because the patient is very sick, it doesn't make sense for me to start him on meropenem. There's no point itself. Okay. If you have a structural lung disease like an ILD exacerbating on top of a COPD, I'd probably want to cover a Pseudomonas. But otherwise, this is going to be regular Streptococcus, which gets treated most often. Till now, we are at least safe on that part, and we can use ceftriaxone. Azithromycin has got other effects also for COPD as treatment. So, if by any chance after 1 or 2 days I feel this is not pneumonia, I can get off the ceftriaxone, but I'll probably keep the azithromycin. It has got other reasons why we want to give azithromycin in these cases, which includes some kind of anti-inflammatory effect and immunomodulation in these cases, which will probably help these cases. Doubtful role, but yes, it has got some kind of signals that says that doesn't. So I would probably keep the azithromycin, but I will get off the ceftriaxone. Clear on that? Now, what is the other problem that you have in these patients? So we just talked about diaphragm. We talked of a combination of acute exacerbation and pneumonia. What are the other problems that you will probably think of here, Zaman? So let's take the example of a patient that comes to you. He's coming to you. He's very breathless. The first thing that comes to him is anxiety. It is very difficult. If you ask a COPD or an asthmatic patient, how was the situation? So I will have someone to die because air is not going inside, and you have to breathe. If you don't breathe, air doesn't go inside. They will die. They will feel that the air is not going inside. It is very difficult to move air from outside to inside in these patients. Why? Because these patients are those patients who have developed a kind of a pressure inside, which is also called as auto-PEEP. There is a development of PEEP inside, which is preventing the air from coming from outside to inside, because this is positive pressure. How are we breathing? We are breathing from negative pressure jets. So you will have to first breathe from outside negative, go less than this negative, and then breathe. Outside, then less than this negative, and then breathe. This is PEEP, right? This much is PEEP. I have to breathe from outside, go less than this PEEP, and then breathe. Very difficult. So moving in air becomes more and more difficult. So when the air movement becomes more and more difficult, he gets more and more tachypneic, the RR becomes more and more lesser, the expiratory time becomes more and more lesser, auto-PEEP more develops and becomes a vicious cycle. Are you understanding what is happening? I'll repeat this once more. This patient is extremely breathless. That's why it's called an acute exacerbation. And he's so breathless that he's coming to your IC. He is diaphoretic. He can hardly breathe. He can hardly move air from outside to inside. At the end of the day, you have to move air. Since he's unable to move air, he gets more anxious. The more anxious you get, the more tachypneic you get. The more anxious you get, the more tachypneic you get. The more tachypneic you get, that means the more faster your respiratory rate, the lesser your expiratory time. The expiratory time will become lesser. Expiration is passive. For things to come outside from inside, from inside to outside, if you want things to go from inside to outside, you need expiration, which is passive. Now the expiratory time is actually coming down. When the expiratory time is coming down, the auto-PEEP will even more increase, the PEEP will even more increase, the CO2 retention will even more increase, and this will cause more tachypnea. Are you understanding? So this patient gets more and more tachypneic. You understand? That is the reason that it becomes extremely difficult to place an NIV on this patient. It becomes extremely difficult to place an NIV because you are already not able to get in air, and then your NIV settings are such that it is causing more difficulty for you. So that is the reason that NIV is supposed to be used at a certain way. You are understanding? So just putting an NIV will not help this patient. It might create counterbalance. It might make the patient more tachypneic. It might make the patient more. You understand? Are you understanding what I am saying?
Yes,
this
sir.
is a very, very important thing. So how do we get around this? How do we get around this? So there are a few methods to get around this. There are a few methods to get around this problem. That this patient is coming to you. This patient is tachypneic. Okay. At the same time, he's anxious and he's actually going through the cycle. How do you get around this? So one of the ways to get around this is to give. We know for certain that it has been proven for certain that you have to use the NIV. That has been proven. It has been proven that acute exacerbation of COPD, if you treat with a non-invasive ventilator, there is a reduction of death, there is a reduction of hospital stay, and there is a reduction of intubation rates. This is very clear. This is very clear that if you use a non-invasive ventilator in a patient of acute exacerbation of COPD, there is going to be a reduced death rate, there is going to be a reduced length of stay in the hospital, and there is going to be a reduced rate of intubation. That is very, very clear. So I have to use my NIV. Now, how do I do this combination clinically? How do I get around this matter? So the answer is, you will need a small dose of some sedative agent. You will need a small dose of some sedative agent. Right? So the answer is, you need a small dose of some sedative agent. So what would you probably use in these cases? You have multiple sedative agents in your hand. You have propofol, you have midazolam, you have dexmedetomidine, you have ketamine, you have fentanyl. There are so many of these agents that are there. So you will have to take the right agent. Benzodiazepines, not a great thing, because benzodiazepines per se are known to cause increased delirium. We know that benzodiazepines can cause increased delirium. It might sedate, but it causes delirium. We know that. We know that from studies where we compared dexmedetomidine to midazolam, showing that these may cause delirium. So we don't want to use as much benzodiazepines. The next drug in our kitty comes as dexmedetomidine. Yes, you may want to use dexmedetomidine, but it is a combination of dexmedetomidine and NIV may be probably the way to go, because it will probably keep the patient a little bit calm. Okay. The third thing would be to use fentanyl. Now, fentanyl is a great drug. Okay, fentanyl here will cause some amount of pulmonary vasodilation, and at the same time will also reduce the anxiety and give a little bit of sedative effect to these patients. You understand? So fentanyl seems to be a great drug to be given. Okay, great drug to be given. And the last drug that you probably want to use would be ketamine. Okay, ketamine is at a small dose. However, it can create its own set of problems, which includes, when I say ketamine, I'm not saying anesthetic dose ketamine. We're looking at pain dose ketamine, 0.1 to 0.3 milligram per kilogram of ketamine. As an infusion. So this is something that you probably want to use ketamine, okay, but it can cause secretions, it can cause its own set of problems. So you must be able to utilize these drugs in a good way. What I would do, I would probably have this patient in front of me, give a small dose of 25 microgram of fentanyl and see what happens. I don't know how he's going to respond. Okay, I don't want to cut off his respiration. That is very important. I can't cut off his respiration. But at the same time, I want him to accept the NIV very well, because I know this is going to prevent intubation, death, and reduce the length of stay. So I want to ensure the NIV goes inside properly. Clear? Clear on this? So I probably use a combination of a sedative agent along with my NIV, and probably the drug I would want to use would probably be fentanyl. Right? I use a combination of fentanyl, maybe dexmedetomidine I want to use, I can use it, but I can't do it on my own. Now what am I going to do on the NIV? We are talking about I'm going to use NIV. So what would I use in the NIV? I'm going to use a combination of pressure support and PEEP. I just can't use PEEP on its own. I can't use PEEP on its own. Please understand this. We cannot use PEEP on its own. You use PEEP on its own, it will become even more difficult for the patient, because we're adding on to the PEEP that is already there on the patient. Are you understanding? So PEEP on its own is not a good idea. So I'll probably use an NIV with a pressure support and a PEEP. I'll use a non-invasive ventilation with an IPAP and an EPAP. I'll use a non-invasive ventilator with a pressure support and a PEEP. Clear on that? I'll use a pressure support and a PEEP, and an FiO2 that will keep my saturation around 88. You understand? The FiO2 is very important. There which I'll keep it around 85 to 88. I don't want it to be very high. I don't want it to be very high. Clear? The second thing is, what are my pressures, what are my PEEPs that I want to give? So I have to ensure that there is very less mask leak in the first place. Mask leak has to be very, very less. Right? The second thing is, my driving pressure should be high. So if my tidal volumes are low, it's not that I'll give 0 PEEP. I'll give say a 5 PEEP or a 4 PEEP. Okay? And then look and keep the driving, if I'm doing 4, I'll keep the driving as 8. Okay, so I'll keep the pressure support as 8. So 8 minus 4 is 4. 8 minus 4 is 4. So I am having a driving pressure of 4. You must understand the driving pressure of a ventilator. It cannot be less than 4. The driving pressure is the difference between your pressure support and your PEEP. So each ventilator has got a different way of showing it. Some will show driving pressure, some will show pressure support above P, some will show just pressure support. You must understand what that is. Some ventilators will show delta P. Delta P is driving pressure. That means if it is showing delta P of 4, it means the pressure support is 8. If by delta P, if it shows delta PS, okay, it means what? My P is 4 and my pressure support is 8. You must understand that when you see the ventilator, because we got different ventilators. You understand that? Huh? So pressure support and P. I want to keep my tire pressure as 4. Now say for example, I now look at my tidal volume, it is coming as 200. I definitely want it to be more than 300. There is no doubt about it. It has to be close to 350, 400. Right? Now so what do I do in these cases? What would I increase here? I would probably want to improve my driving pressure. I want to improve my driving pressure. So if my driving pressure is 4, I'll make it 8. I'll make it 6. So pressure support and P. This is what I will do. So I'll increase my driving pressure. I have to be very careful here. I have to be very, very careful here. Anything that I do on the NIV can have very bad effects on the patient and can have very good effects also on the patient. And that comes to the question, what am I going to monitor? Okay, I saw that error should be 200. Okay, and my 200 is going to 400. But importantly, what I am going to see, whether there is a drop in the respiratory rate, whether there is an improvement in minute ventilation, whether this patient is feeling better, whether the sounds in the chest are better. You know, these are the things I am going to look at. These are the things I am going to look at. You are understanding? So you might think, let me do a blood gas for that matter. So we really not concerned. So the first question is, if I'm going to investigate this patient, let me do a blood gas. Okay, you may want to do a blood gas, but the blood gas can be either arterial or it can be venous. You can do any of the two. Arterial is very painful. Venous is not very painful. You can do venous blood gas. You don't need an arterial blood gas there. The venous blood gas will give you the carbon dioxide when it's there. Are you understanding? If you want to, if you are thinking that the CO2 narcosis is the problem, is the problem over here, you should not. That is a history actually. The CO2 narcosis is a history. You know, you will know that this patient was okay. After why do you do the ABG just to differentiate between CO2 narcosis from your sedation versus CO2 narcosis from your respiratory distress? That is the only reason you would like to do it. You understand? That's the reason you want to do a blood gas. Others you don't need to do a blood gas. Now the blood gas has got a variation of 5 millimeters of mercury and a 0.03 of pH. That means it can be 7.1 or 7.13, or it could be 45 versus 50. 50 sounds dirty for you, 45 sounds normal for you. Are you understanding? 45 sounds normal, but 50 sounds dangerous, isn't it? But you must understand this is normal variation. This is normal variation. So 5, if it is 50, it can be 45, it can be 55. If it is 40, it can be 45, it can be 35. So there is a 5 variation that occurs with patients who with a normal blood gas. So today, if I want to say he was 55, I have given my BiPAP, it has become 50. You are a dumb idiot. Why? Because 5 is the normal variation. Are you understanding? So that is why targeting that PCO2 with doing blood gas, I am saying that oh, this patient's PCO2 has improved, doesn't make any sense. Are you understanding? Let me give you an example. You have a patient that is there in the ICU. He is an acute exacerbation of COPD. You decide to put the patient on NIV. And the blood gas initially showed you a pH, showed you a PCO2 of 65. That's why you put this patient on NIV. Now, this patient, you put the patient on NIV. He has subsequently improved, including clinically he has become better, pulse rate has become better, saturation has become better, okay, he's not breathing heavily, his diaphragm has gone down. Clinically I can see him getting better. Now some dumb nitwit comes and decided to do a blood gas. Okay, and you do a blood gas, your PCO2 was 65, now you need a PCO2 of 60. So he says, yeah, PCO2 is 60, increase the pressure support further, let him get ventilated better, he's not getting better. What has happened? You are treating that number there, where 60 would have been 55. Just because it has dropped only by 5 millimeters of mercury on the blood gas, you might be tricked to understand that this is not improved. You need to increase something. and then you increase the pressure support, and likelihood is that you increase the pressure support, the amount of pressure inside the lung keeps on increasing, and later on from 60 it becomes 80. This idiot repeats the blood gas again and it becomes 80, and then he says he's not doing well, let's intubate him. Are you understanding? So what is the underlying crux of the story? It is the clinical examination that makes the biggest difference when you are dealing with NIV. That is why as a bedside doctor, what you are supposed to see, once you have used some therapy, what is happening to my patient? What is happening to my patient? That is very, very essential. So when do you expect this to occur? When do you expect this patient to get better? You are expecting the patient to get better within 1 to 2 hours. You are expecting this patient to get better within 1 to 2 hours. You cannot indefinitely wait for this patient to get better. You are expecting this patient to get better after your treatment within 1 to 2 hours. Are you understanding? So remember this. If you have gone to a condition where you are intubating this patient at the start, the severity is very, very high. If this patient is coming, now I want to change. The first question was how you gauge the severity, isn't it? If you come to a condition that this patient you have intubated on admission, irrespective of whether he wakes up well, his severity is very, very high. Very, very high. If you have put the patient on an NIV, and then after a day you have intubated this patient, his severity is extremely high. His severity is extremely high. You understand? If your patient is coming to you and you have quickly intubated this patient, very carefully intubated this patient within 1 or 2 hours, you understood that there is an issue and intubated it, that is the patient that you can probably wean off more than any other patient. So, understanding this? So I'll just repeat this once more. If your patient comes in and you have intubated him on admission, that patient is extremely sick. He's extremely sick. Okay, his mortality will be very high. He will not do well. Things talking about the doctor. If you have a patient who has come in with sickness, okay, and in 2 hours time you see he's not improving, and quickly ventilated him. This is one of those patients that probably you treat the pneumonia will get kind of better. And one of those will get kind of better than the pneumonia patient. The other extent, that is you put the patient in IV and 1 or 2 days later you intubate, they are the worst of the lot. The improvement will be almost next to impossible. Are you understanding? So, what is the crux of the issue? Clinically, I must understand where I must intervene. It all depends on that. If I intervene well, this patient will do well. Understanding? So, what happens over here? 1 hour later, I am looking at my pulse rate, I am looking at my blood pressure, I am looking at my patient, and I am putting down on paper what is happening here. So, if I see a 20% change from my existing response that was when the patient came in, I am expecting this patient to do well. You understand? 20% change is the answer. So if you have 140 and now you see the pulse rate 110, I am kind of reasonably assured that this patient is probably going to do well. Are you understanding? Clear on that? So there are a few things that clinically you must see on these patients. Clear? Clear on this? Clear? So now what are the drugs that I would use here? Of course, it just can't work without giving medication. So what are the drugs that I probably want to use here? The drugs to use over here, the first drug that I probably want to use is a bronchodilator. Okay. Now you may say, ये तो COPD है, irreversible airway obstruction है, ये bronchodilator कहाँ से काम करेगा? You're right. It may not work as well. No, you're kind of right. It may not work. What can work better is an anticholinergic. Okay, what is going to work well is probably an anticholinergic, ipratropium bromide. That will probably work better than a bronchodilator. Bronchodilator works well when there is a reversible airway. What is the reversible airway? Asthma. So you must understand what drug I want to quickly put in. It's very important. In COPD you can target the inflammation. In COPD you cannot target bronchospasm as much. Right? Whereas in asthma you can target bronchospasm more. Are you understanding? So there, if I have to start a drug in asthma, I would say immediately start bronchodilators and let it go as an infusion and all these things. Let it go every 2 hours, every 20 minutes, every 30 minutes. Makes sense. But here, that may not be the way it may work. I may want to give more of steroids in these cases rather than the bronchodilator. I may want to give more of ipratropium bromide, anticholinergics, as compared to a bronchodilator. I will give bronchodilator, but I know on the back of my mind that this is not something that might help this patient much. Clear on this? You're understanding? So what is the dose of the steroid that you're going to give? What would be the dose? So there are various studies that have looked at doses here. Various ways of doses. And what is known is that just a 125 milligram methylprednisolone is enough. So you may want to give it once a day, the other way. It's not like you have to give it 3 times a day, 4 times a day. You understand? Just a 125 milligrams of methylprednisolone should be enough to target the inflammation of the airways. Understand this, when you give 125 3 times or 4 times, you're giving 300 milligrams prednisolone. It is dangerous doses. You know, sometimes people come and write 125 4 times a day. 400, 500 milligrams of methylprednisolone, which is 400 milligrams of prednisolone. A huge dose. We don't give it for transplant also too much. Are you understanding? So we don't require so much high doses. Because there are after effects of those steroids. There are huge after effects of those steroids. What is known is that 125 milligrams of methylprednisolone is enough in these cases. Clear? So you may want to give it as 40 PD or 40 dd as much as maximum. Or you may want to give it as 125 milligram per second. Clear? Am I clear with this? So that depends on your patient, right? So what we know is that whenever we give a steroid for 4 days, you don't need to taper. If you give it for more than 4 days, there is a possibility that you may alter the HPA axis, and so you want to taper. But more often than not, these are those patients who have got chronic inflammation of the airways. So these may be one of those patients in which the steroids will never stop only. They will be at a small dose of predmed towards the end. There will be a small dose of methylprednisolone when you are discharging 5 milligram, something will be there on these patients, or they will be converted into nebulized steroids. So steroids in such exacerbations who are so bad, coming to the ICU, okay, will probably not be omitted in their entire life. They will be on prednisolone, or they will be on nebulized form of steroid through metered dose inhibitors. So that comes to the question: what kind of nebulizers are we using? What kind of nebulizers are we using? So if you have a patient that comes in over here, okay, and you have to give a nebulized ipratropium, you know now that if I don't give a drug like this, my NIV is not going to work. It's not going to work well. You understand? I'm just not going to improve if I just give fentanyl NIV. I need something more than that. I need a drug. I need a medication. It's not going to improve otherwise. So how will you give? So the route becomes very important, isn't it? IVM with methylprednisolone, but that's inflammation. It's going to take a while. I need something quick. So one of the quick drugs I'm going to use is anticholinergic. It's ipratropium. How do I use it?
So NIV only, we can give.
So the answer is what you're using here is what you're supposed to do. What are we using here? We're using something called vibrating mesh nebulizer. What we're using here is a vibrating mesh nebulizer. First of all, would I remove my mask and do it? No. I will not remove my NIV. It's very essential for you to understand this. I will not remove NIV and give nebulizer to a machine. No, I will not do that. Whenever I'm nebulizing my patients in an acute exacerbation of COPD, it has to be without removing the NIV mask. It has to be without removing the NIV mask because your drug disposition is much better with an NIV mask as compared to without an NIV mask. Right? So I would want to use a vibrating mesh nebulizer. That would be probably one of the best nebulizers to be used in these cases, so that these go to the small airways. What are we wanting to ventilate? The small airways. And to reach the small airways, I need particle size of more than 5, somewhere around 5 to 10 microns. And that I will reach only when I am using a vibrating mesh nebulizer in a good quantity. You understand? So it's a vibrating mesh nebulizer that I will use in these cases. Along with an NIV, which will allow this drug to be deposited in the small airways so that it will act quickly. Now how frequently do I give that? So if it's an asthmatic, I would want to give 10 to 15 milligram an hour of say albuterol or salbutamol. Per hour, infusion I'll give 15 milligram if I want to put into that a vibrating nebulizer, let it go, but it has to be quick. So I may want to give it fast. In these cases, it may not be required to be given fast because it's not going to work like that. So I would probably give ipratropium bromide 6 times in a day, or 4 times in a day, maybe 4 times in a day, prednisolone, and then probably work with limonene pills. I don't know for whatever benefit it might be, but I know for certain it is equivalent to a placebo. I know that limonene for certain is equal to a placebo most often in these cases. Levocetazine. Clear? So this is the drug I will use. So drug I'm going to use is this. The rest of the drugs, for example, aminophylline, are all drugs, aminophylline, magnesium sulfate, innate anesthetics. All this would come in use only when you are actually dealing with asthma. It may not work in a case of COPD. So what is the crux issue in COPD? Your ventilator has to work well. Your NIV has to work well. And the rest of the things are support. The rest of the things are support. More often than not, these COPD patients will be on nocturnal BiPAP all their life. Most of these patients who are going to be on NIV support to begin with would be on NIV for their life. Nocturnal BiPAPs they'll be on, nocturnal NIVs they'll be on, or they'll be on NIV half part of the day as much as possible, intermittent BiPAP. They'll be on those cases because they are not those patients who have come to the ward. They are those patients who have come to your ICU. So the severity of the illness is much higher as compared to the rest. Right? Clear? Now when it comes to intubation, another extremely difficult thing to do, intubation. We've come up with a management where we've understood the drugs we're going to use. So as far as possible, what you have understood, I don't want to intubate. As far as we've understood, I don't want to intubate because I have a tool called NIV which will prevent my intubation. Are you understanding? There is a tool in my NIV called as NIV which will prevent my intubation. Clear on that? Clear on that? So I don't want to prevent it. I don't want to do this intubation. So even if I come to a condition where this patient is so somnolent that he's not waking up, I might still try my NIV for a while, for 10 minutes or so, 10 minutes or so, to ensure whether he wakes up or not. Because once he wakes up, his diaphragm is he'll start breathing problem. You understand? But I will not, if it is a complete situation where he is down completely, he is gurgling, that is not a patient who will try my NIV. He is not maintaining his airway. He needs to be intubated. So here, the intubation is extremely dangerous. Extremely dangerous. There are many reasons why it is dangerous. One of the reasons that is dangerous is your oxidative pressure you are putting inside. The entire problem is positive pressure. And now what you are doing? You are actually giving positive pressure. So in the event that you have enthusiastically taken up this patient to ventilate and you now hold a mask, there is a very high possibility that you will press the ambu bag. When you press the ambu bag, there is going to be a huge volume that is going to go inside, okay, and not come outside like the way it is supposed to come outside. Which will you think that I might be ventilating and getting carbon dioxide out, but what you are doing is actually you are putting pressure inside. You are actually putting more air inside. You are actually increasing the positive pressure. More often than not, what happens is the positive pressure in your lung keeps on increasing, reduces your jugular venous return, your JVP return comes down, and this patient suddenly arrests. If there is no venous return, there is no cardiac output. If there is no cardiac output, there is no carbon. Then the patient arrests. There is no output. Okay, the patient arrests. You understand? So you cannot. It is so difficult in these cases to pre-oxygenate that is why you don't delay your ventilation. Don't delay that ventilation part of it. You delay the ventilation part of it, he will die because of the hypoxia that will probably occur later on. You understand? The second thing that occurs in these patients is the fact that these patients are very dehydrated. They are very dehydrated. They can't even speak, let alone drink water. You understand? Food to khane se dur ki baat. They can't breathe. They can't speak. So water to dur ki baat hai. So they are actually dehydrated. The amount of respiratory rate that they have dehydrated themselves tremendously. Are you understanding? So these patients don't do. So the moment you give them something for putting them under intubation, so for intubation, he may just drop his blood pressure. So it's important to hydrate them at that particular moment when you're intubating. Right? Another mistake that we do is we just intubate, put the patient on the ventilator, and we forget it. That is the worst thing you can do in these cases because here the ventilator parameters have to be set so perfectly that if you don't set it perfectly within 15 minutes, this patient will arrest. As it has occurred many times. You put this patient on the ventilator, 15 minutes later, patient is arrested. Why the patient arrests? Not because he's developed a pneumothorax. He's arrested because this patient developed autopneumonia. Are you understanding? So it is very essential for you to be bedside, to understand what is happening. See that the flow is reaching its baseline. There is no development of autopneumonia. Nowadays, the ventilators are so good, you can see the waveform. You can actually press a button called as autopneumonia intrinsically. We can figure out all those things. It is so good, the ventilators.
Okay, so you have to figure that out. So what would be your settings in these cases? The lowest possible tidal volume, the lowest possible rate, and the highest possible I ratio. Okay, this would be your set rate that you're going to use at. Set settings. The lowest possible, if I were to maintain a saturation of 80 to 90 and lowest possible tidal volume. Okay, the second thing would be a lowest possible rate, that is 10 or 11. 10 or 11. And you will also have an I ratio that is probably going to be much higher. So every ventilator does not have an I ratio adjustment. Some ventilators have to adjust the inspiratory flow. So if there is no I ratio, then you can adjust the inspiratory flow. So if you that's called TI on that. So if you adjust the inspiratory flow, your I ratio will change automatically. But it's important that you understand these three things. And these four things: FR to tidal volume, RR, and I ratio. After you set it also, you have to again check what is happening to my autopsy. What is happening to my image? You don't assume that the blood pressure drop is because of the anesthetic agent that you have given. Right? And that comes to the point we have to remove one subjective problems. For example, you have an anesthetic agent. I don't want the anesthetic agent to interfere with what's happening over here. What anesthetic agent is? Ketamine. Ketamine does not cause drop in blood pressure, does not cause drop in respiratory rate as much. It does not cause drop in pulse rate as much. It's a very stable drug and it causes the effect of bronchodilation. So I probably want to use ketamine. Clear? Now, after I've intubated this patient, remember this: when he wakes up again, he starts breathing fast. He will start breathing fast. Why will he start breathing fast? Because he is having a problem. His COPD is having. He's going to breathe fast. So you don't assume that this patient, after intubated, will become normal. He's not going to become normal. He's again going to breathe fast. And once he starts breathing fast, your ventilators now are all assist control modes. Your ventilators now are all assist control modes. He triggers, he gets. He triggers, he gets. He triggers, he gets. Breath stacking will take place because he's not breathing at 20. He's breathing at 35. So breath stacking. So 200, 300, go on. Suppose it is assist control mode. You are going to put this patient in usual assist control mode. This will cause breath stacking. So instead of giving mid ventilation of 8 or 6, you will get a ventilation of 16 or 18. Are you understanding? What does that cause? Again autopsy, again exacerbation, again worsening and vicious cycle. So it's important for you to get this patient silent. That doesn't mean paralyzed, because we know a combination of paralysis and sedation increases length of stay and causes more amount of critical illness, polyneuropathy, myopathy. We know that. So it doesn't mean paralysis. In the start you may want to paralyze, but then very quickly you need to give a silent dose. I call this a silent dose because we want to keep this patient silent. We don't want him to breathe heavily, which will completely prevent everything. Our entire problem when we started talking was get down the diaphragmatic fatigue. The first thing, get down the diaphragmatic fatigue. To get down the diaphragmatic fatigue, I don't want him to stop breathing. I want him to breathe comfortably. Are you understanding? I want him to breathe comfortably. The ventilator should breathe with him comfortably. What do? I want to give some kind of an agent that will not drop his RR majorly, but will give him a little bit of sedative effect so that he remains stable and removes the pain that comes in from here. What is the drug? Ketamine. So probably want to use ketamine here. 0.1 to 0.3. Given an option, ketamine would come first. 0.1 to 0.3 milligram per kilogram per minute is what I probably want to use. Right? If ketamine itself, I don't want to go to anesthetic dose ketamine because it has got its own problems. We are in pain dose ketamine. We are in pain dose ketamine. We are on anesthetic. Anesthetic is 2 milligram per kilogram. 2 to 3 milligram per kilogram is anesthetic dose. You understand? We are in pain dose. 0.1 to 0.3 maximum to 0.5 milligram per kilogram of ketamine. You understand? So we have to be at that dose of ketamine so that we can actually help this patient to coordinate with the ventilator in such a way that there is no more problems that are coming inside. Clear? So how long will I ventilate this patient?
24 to 48 hours.
So it is obvious. Remember this. Whenever you have these patients, you put it till they wake up. They just wake up. They say, "Arey, ya to ud gaya," and then you say, "Chalo, switch me to वापस input हो जाए." Are you understanding? So we've made these mistakes in the past. We should not repeat. We've made these mistakes in the past. It's happened like this, that you intubate and then the patient just wakes up. You make him sit on a chair. He sits on a chair. You feel wow, and you remove the tube and he gets intubated because diaphragmatic fatigue is there. That is the importance of doing an ultrasound in these cases.
And when you do ultrasound in these cases, you will probably want to use the patient want to be TPs and then you will ultrasound to understand that the diaphragm, how the diaphragm is moving. Is it moving less, moving more? That's where diaphragm comes. That's a little bit of a complete overkill for this topic. But when we do diaphragm ultrasound, we'll talk about it.
So this is applied for any respiratory distress, like not in COPD, like patient is in failure also, like patient get fatigued no, with due to breathing.
Good question. So the muscle that get fatigued last is always a diaphragm. You understand? It's not the muscle that gets fatigued first.
Yeah.
The respiratory failure, these patients, because they have COPD, they are already at a fast RR at home also. At home also they are breathing at 20, 22, 23. When it gets a little bit more than that, that is when they come to you. Understanding? So their fatigue level is already on the higher side. So when they come to you, they are so fatigued because that is the cause of his somnolence. Whereas in a respiratory failure from another origin, where you have say ARDS or pneumonia, what is happening over there? It is the pneumonia that's causing it. Diaphragm is not fatigued, he is just breathing fast. Are you understanding? So he will not get a carbon dioxide narcosis.
Yes.
You never see that.
Yes, sir.
You never see that. In a respiratory failure, what do you see?
Pseudonarcosis.
In a respiratory failure of ARDS, what do you see?
Hypoxia.
Hypoxia, and what happens to the PCO2?
Rise.
It reduces, no?
Reduces.
Why does it reduce? Because diaphragm is working excessively. Diaphragm doesn't get fatigued. It is the last muscle to get fatigued. You understand? So when you did your physiology experiments, when we had a physiological experiments in anatomy, when you do anatomy physiology, we had that experiment of taking a diaphragm and then stimulating it. We all did that when we were in first MBBS, and we found that diaphragmatic fatigue was much lesser than any other muscle fatigue. Skeletal muscle versus diaphragm muscle, we should do that. I don't know whether you all remember it. We've done that. We all had done that to understand the difference between a diaphragm muscle and a skeletal muscle. We saw repetitive skeletal muscle stimulation. So that muscle gets. That's why you don't need strength to move your diaphragm. When you start getting that condition, when you need strength to move your diaphragm, then you are towards the end. That's why the severity becomes very, very high. When you come to that condition where the diaphragm is not moving, that's your powerhouse. So if that's not moving, then you are in a condition where the accessory muscles are 20% of your, 10 to 15% of what you are. 80% is your diaphragm.
That time the paradoxical respiration starts.
Yeah.
That once.
But you will not reach that. COPD will be.
Yeah.
You should not reach that stage. You should be much before that stage, where diaphragm is zero. You understand? We cannot reach that stage. That is why these patients become somnolent. They become somnolent because diaphragm being 80% of your respiratory ventilation, it's not working. That's why they're getting somnolent. That's why they're getting pseudonarcosis. But otherwise, normally you don't get it. No. Even if even in a condition of respiratory failure, you're breathing heavily. PCO2 is still 20, 21 because diaphragm is working phenomenally. When that time becomes 40, you are worried. If at the time of distress the PCO2 is 40, you are worried, no? Because if it reaches 40 at that stage, probably diaphragm is fatigued up. You have lost your reserve. You understand? So that will be very rare going to that level. So,
Yes.
for example, we had that patient, that old man who was there. Yeah, so in that case, you can't tolerate a 40 PCO2. A 45 PCO2 there at a distress is definitely a sign that he is going to get a ventilation. You understand? And the more exacerbated they are, the more difficult to get them off the ventilator. This is an issue. Clear? So we've dealt with bronchodilation, we've dealt with, this is all simple, this is all very simple to do. But if you now understand, COPD is completely clinical. You can't say A particular drug is work or B particular drug is not to work. It is all are simple drugs. There is nothing major about any of the drugs that you're using, but it is actually the clinical skills that work. It's your clinical skills is where I'm going to intervene, how much my NIV should be. So it is a continuous process. So you can't say I put a pressure support of 10 and a PEEP of 5 and this patient is going to do well tomorrow morning. Because it's a high possibility that in the next 3-4 hours this patient's pressure support needs to be reduced or needs to be increased. Something will happen, no, because there is going to be bronchodilation, more about a volume or something. Something will happen. It's not going to remain at that level. So you may have to alter it. So that's why if you know how to use the NIV in these cases, more often than not your COPD patients will do well. You can't just put a setting, sir, setting it cannot work that. It doesn't work that. It has to be changed. If you have the same setting from morning till next day morning, it's probably nothing. You don't understand what is happening. So now this NIV compliance becomes a big issue here. Big issue, because this is one of the places where we are telling don't remove the NIV.
This is one of the places where we are saying don't remove the NIV, isn't it? This is one of the places. In cardiogenic pulmonary edema we are saying ठीक है निकाल के खाना खिला दो. इसमें हम बोल रहे हैं कि NIV मत निकालो. इसमें डायफ्राम फटीग्ड है, वेट नहीं कर अब ज़्यादा रख नहीं सकते हैं. So first 2 days ना don't think of feeding. First one day don't think of feeding. It doesn't make sense. There is no point. It's not going to change anything. Are you understanding? First day let him breathe. तब वो खाएगा. जब वो सांस लेगा तब वो खाएगा बाद में. हाँ तो let him first breathe. And what is also known, what is very clearly known is if you feed these patients aggressively in the first 1 or 2 days, the mortality is high. These patients will not do well. There are airway complications that will occur. So don't feed them. First 2 days, lie low, not required. Because what is going to happen over here, to try to feed them, you will try to remove the NIV. Every time you remove the NIV, वो 1 second में तो खाने नहीं वाला है वो. It's going to take 10 to 15 minutes. The entire cycle repeats again. Again he starts filling in. Again he starts getting weak. Again he starts getting worse. Are you understanding? And everything that you've done, you lost. Second thing, you decide, no, I'm going to use a highly specialized mask where I'm going to have a Riles 2 port inside and I'm going to go inside and I'm going to feed these patients. What is known is that when you're feeding these patients, you have a patient that, you feed these patients. So what is going to happen when you're feeding these patients? What is known in a large study that was done among, if I'm not mistaken, it was a group of French ICUs, 49 ICUs. Those patients in which they fed them, they had more amount of airway related complications. So the underlying point is, don't push the feeding. Nothing is going to happen in the first 1 or 2 days. Let him first breathe well, but maintain that patient compliance on the BiPAP. So that is why take that opportunity to remove the BiPAP for some seconds and let him breathe and then put it back. Don't take it out, make him eat and put it back. Are you understanding? Because otherwise what you say? Remove the BiPAP, make him eat, put it back. Don't do that. Remove the BiPAP take that time to improve his compliance. Take that NIV free time to improve the compliance. Nobody wants an NIV all through the time. It is painful. It is very, very painful. It is extremely painful. Okay? So on an average every 2 hours, the NIV should come off. So if you're going to tell that average NIV, remove the NIV and remove it for after 2 hours, remove it and keep it aside for a minute or 2. If you're going to tell give feed also, your feeding is not going to get to 1 or 2 minutes. It is going to take 15-20 minutes, half an hour, 1 hour. By that time again the whole cycle will repeat. First 2 days don't think about this. In fact, it is the other way around. If I remove the NIV for a span of even 3 minutes or 5 minutes, I put an HFNC in these cases. So alternate the NIV with the HFNC in that time. Don't let him be without anything. So now the HFNC becomes very important here. At this stage, say the patient has got better and you feel you can feed him something with the HFNC on board, it may be a good idea. So small amount of feeding if you want to give just for the sake, let him have some juice, let him have some fruit juice, he'll wet his mouth, he'll feel better. At that time give him a fruit juice, he'll feel better. But you cannot give it without giving an elaborate meal, 5-6 things, dal, roti, chapati, No, you don't need to do that. Give him a juice to drink. And what is known is when you put HFNC, the airway complications are not as much as the NIV. There is something called DLVB, delayed laryngeal vestibular closure. DLVB. So what is DLVB? It is a time it takes to close your laryngeal outlet when things are going in the wrong place. What is known is that this, you understand this? How do you eat? Because the laryngeal vestibule closes. That's why it goes into the esophagus. Laryngeal vestibule closes. That's what you're reflexing. Nothing goes inside the airway. Okay? That latency, the speed and the effectivity goes higher when you are on HFNC. So the HFNC works also to protect the airway much better than the NIV. This is not seen in NIV. Delayed laryngeal vestibular closure is actually becomes more delayed. Okay, more delayed. And that's why feeding these patients is not a good idea when they are on NIV. You understand, latency ज़्यादा हो जाता है इसमें. Okay, that is the reason that airway related complications are much lesser when you are actually using HFNC. So what do I do? If this patient is getting better by the next 12 to 14 hours, and now I feel I have to wet his mouth because it's all dry. Everything is very dry in the mouth.
give him some amount of juice and he start getting better. So he get better. But the compliance, you have to improve compliance. For compliance, you need to get the NIV out at regular intervals. For compliance, you have to massage the area of the face. It has to be massaged because as you're pressing it, the capillary refill is going down. The capillary refill is going down. So the massage has to take place of that of the face. For compliance, the patient should have wetted his mouth. Otherwise, he will go mad. He will go mad with the amount of dryness in his mouth. He can't talk. Many of you have seen that. You remove the NIV, they can't talk also properly because of the dryness in their mouth. They can't even talk properly. So to improve compliance, what your round is involved, you have removed it for now. निकाला है क्या 2 घंटे के बाद निकाला है क्या? हाँ निकाला है, बहुत मसाज किया है क्या? The patient feels like a world of a difference when you do that. Patient feels a world of a difference when you do that. Patient starts feeling better. Patient's compliance improves. At the end of the day, what have we started by saying? The only thing that reduces mortality, or that reduces ventilation, or that reduces negative stay is
NIV.
So our entire thinking would be, how do I get my NIV done well? You understand? And your entire concentration should be based on that. If you don't concentrate on that part of the story, nothing is going to improve. Nothing is going to improve. That is beyond doubt that you know about this thing. Clear? Clear on this? Any questions? You want to start some fluid? You can do that. So this patient does not have normally, they don't have cardiac problem. They don't have respiratory. They only have, classically these COPD patients will have only a respiratory problem. Very less often you have COPD with LV failure, and that's a very complex case. That becomes extremely complex. If you have COPD with LV failure, already RV is gone down, it is very complex. We are telling simple thing like just with COPD the mortality is high. Now you see COPD, LVF, renal failure, you are in a different league only. The chances of survival is a little less. We are looking at patients that will survive, and those patients who are just the patients that come to you are going to be these ones. The middle-aged COPD or the slightly elderly COPD who comes in with nothing else apart from maybe some small diabetes and hypertension, not with LV failure, renal failure. It's beyond. It's very difficult to manage those patients. But giving fluids will always help these patients. Why do they help these patients? Sorry? They are dehydrated. But more importantly, what is happening? Secretion drainage gets better. When you give fluids, what is happening? The secretion drainage gets better. Because otherwise all the secretions inside become plugs. They become very difficult. They become difficult to remove. Airways cannot remove, they cannot cough it out. Issue is that. So you give them fluid, the secretions become thinner. Of course, that doesn't mean you blast them with fluids. That is why you must be careful when you giving fluids. You give them in boluses. So that's why I don't prefer to give maintenance fluids. You give them in bolus, they band ho jata hai. 500 deke band kar diya. Average we know these patients require how much? 30 to 35 ml per kilogram per hour. So I'm going to give that much. So for an average person, 1.2 to 1.5 liters has to go inside. I know that. So that much amount of fluids I will give. I might give slightly higher because he's on NIV. So maybe I'll give around 1.8 or 2 liters. But I may give some amount of fluids. Yes, but I will not refrain from giving fluids. I will give some fluids to these patients. You understand?
It's about home backup. With all the prescriptions, but we don't give home backup to everyone. So to whom we should prescribe home backup at home? So it doesn't occur.
So if the patient is very severe, more often than not, these are going to be those patients who will be on home backup. So the patient that comes to the ICU, 80% of them will go back on home backup. 70-20% of them will go down because there are those patients, the extremely severe, the board index is very high. Those patients who came in and got intubated. These are those patients who may be requiring home backup. Of course, that call is taken by a pulmonologist based on the earlier pulmonary function testing and what is the situation now. If he's in the severity category where in the last 6 months he's had 2 exacerbations and he got intubated this time, more often than not this patient will require home BiPAP. They require nocturnal BiPAP. They are not usually just COPD. They usually obstructive sleep apnea is coming in along with COPD. Your basically hyperventilation coming along with COPD. There are things like that comes in. So they may require. It all depends on what is your blood gas, what is happening, how is he feeling. It all depends on that. So there is no criteria that says this patient will require home BiPAP. There are only judgments and guidelines that say, okay, this is the situation, so let's start with BiPAP. So what home BiPAP, what you must understand is it is not to be started to begin with. You cannot start a home BiPAP to begin with. So if a patient comes from outside and he's got his home BiPAP and he says, मेरा hospital का BiPAP मत use करो, इसको use करो. You're not going to do that. Why? Why? You understand? Now home BiPAP में तो छोटा machine जिसमें हम use रहता है.
सेटिंग फिक्स रहता है प्रेशर.
Setting fix किधर रहता है? We can change the diaphragm.
No.
We can change.
And
Sorry. What you can monitor? Sorry. So usually you can't see compliance. It's very difficult to see on the NIV, you know, because they're not fixed. They're not closed airways. Compliance is very difficult to figure out. What is important? So there's a big difference with the NIV that comes from home versus the NIV that comes at the hospital. These ventilators that we are using are ICU NIVs. The ones that come from home are home NIVs. They are one of the big constructional features that are different is that you have got two limbs over there, whereas the home NIV is only one limb. They have one limb circuit. There are two limb circuits in our ICU. Now, why there are two limbs? One is an inspiratory, other is an expiratory. So you have an inspiratory limb and an expiratory limb. So where is the expiratory limb here in the home NIV? Where is the expiratory limb? So there is no expiratory limb. There is only a small hole. There is only a small hole closer to the mask or closer to the machine. There is only a small hole closer to the mask or closer to the machine. So there is no expiratory limb there. Okay, so that's the first constructional difference that you have. The second is these ventilators have got softwares which actually can target your FiO2s. So you can target your FiO2. You can give 20%, you can give 24%, you can give 30%, 21, 24, 28, 30. You can make it like that. They got blenders inside. They got blenders that take the oxygen from the wall, the air from the wall, blend it, give you an FiO2, and that FiO2 you can give to the patient. Whereas these NIVs that come from home, there is no oxygen. This oxygen that is attached, but you don't know the FiO2. You cannot regulate the FiO2. You're understanding? Third thing, these home NIVs, the monitoring capacities, as you said, is much lesser. But what monitoring? I don't know the tidal volume going inside. I don't know what is happening inside. I don't have a waveform. I have no idea whether there's a leak. Nothing I know. Nothing I know. Whereas in these ICU ventilators, you know how much tidal volume you just now discussed. That I'll increase the pressure depending on tidal volume. Can you do that with this? You can't because you don't know. You don't know what the existing tidal volume is there. So you can't use the NIV from the home for adjusting tidal volumes. You don't know what is happening over there. Fifth thing, these NIVs that you had at home does not have a respiratory rate. So if the patient breathes, he breathes on his own. There is no way you can change the RR. Whereas here, there is a possibility that you can give a certain amount of RR to this patient compulsorily. But if you can set a RR of 12, you can give 12 breaths. Whereas in the home NIV, there is no way you can adjust the breath setting unless you take a very high-end AVAPS machine. Unless you take a very high-end AVAPS machine, okay, which actually will give some kind of AVAPS machine, some kind of very high-end Philips machine, which will actually look at all these things. Clear? Clear? Huh? Put up the others.